Okay, welcome everybody to our weekly Q&A session with Toronto's Associate Medical Officer of Health, Dr. Vinita Dubey, joins us again today. Thank you, Doctor, for being here with us today.
Hi again.
Hi, so my name is Dilshad Burman. I'm a reporter and web writer with City News and 680 News, and I will be moderating this chat today. This chat is comprised of all of the questions that you, our audience, have been submitting all week. If you haven't had a chance to submit your questions, you can do so as we are talking live right now under this broadcast, and we'll try to get to as many questions as we can live as well. For now, we're going to start with our cache of questions that we've been collecting all week. So, Doctor, are you ready to go?
Yeah, let's go.
All right, let's start. So we'll start with one question that we've actually had 3 people submit a very similar question. Toronto mask wearer, Cindy and Sam have a very similar question. They ask basically, is there a new acceptable daily positive COVID case count for where we are currently standing in this pandemic? Because the goal of 0 positive cases per day is not really possible right now. So what is the current acceptable parameter? And, you know, once we pass it, are we going into lockdown, or when are we going into lockdown?
Yeah, it seems that the numbers keep creeping up, don't they? And I can say, I mean, we've talked about this before. In the city, even in the summer, we never really saw 0 cases through a continuous stretch. We always had a few cases reported every day. And now, though, I mean, we're in the 500s, and that's certainly not a place that we want to be. There's more than just the case counts, though, to look at. I mean, the case counts are one thing. The question is, though, who is getting infection? We're starting to see more cases occurring in long-term care homes, outbreaks in long-term care homes. That's more concerning, but also a reflection of the community spread. But we also look at, on our website, we have what's called a monitoring dashboard, and it looks at things like the average number of cases, where are cases getting their infection, but also at our healthcare system. How ready are we to admit people to ICU? Do we have beds available? That's a key indicator, as well as our lab capacity. Are we getting the results as fast as we need them in order to be able to respond and to do our public health follow-up? So it's more than just the case count that we look at. That being said, we do want to see a slowing of the case count. We saw when we went into our modified stage 2 in Toronto, the cases continued, but that accelerated growth, where after 8 or 9 days, we saw a doubling of our cases, that slowed down. And so we do want to see a slowing of cases. In the new provincial framework, there's that, traffic light system that we talk about for progressing, and one of the stop measures is actually the lockdown, though that's not clearly articulated what the measures in the community need to be. So I think that's another good place to look at to kind of get a sense for when we might be headed that way. We certainly want to prevent that, because we know that that's an extreme measure, and so we want to be able to control as much as we can before we get there.
Right, and there's no magic number, like we're not waiting for 800 cases a day and then we're shut down. There's no threshold that we're looking to actually hit. It's just, like you said, a cumulative of the various things that you just mentioned, whether it's testing, whether it's how fast we're getting our results, etc.
Yes, and the parameters for lockdown have not been articulated provincially, so that is something to look out for, whether that might come. But it will be more than just a magic number. It will be looking at the sum total. Yeah.
Mm-hmm. Okay. And then another question that we have from 2 people, Jen and Jessica, are both asking about PCR testing. So I'll just read out Jen's because it's similar to Jessica's. The PCR picks up viral corona debris, she says. High amplification is being used, which means there are high false positives. Do you consider this a trustworthy test, and why are we still using it?
So it doesn't pick up debris per se. It's actually a genomic type test. So it looks for the coronavirus gene. That's what it actually amplifies. It doesn't necessarily pick up live virus. Like, we can't tell when we collect coronavirus whether that's actually live virus in there or not live virus. But it does pick up parts of the gene of the virus, and and in doing the test, it amplifies it to see how likely it is that this is actually a COVID test. The false positives in the PCR tests that are done, when you go to a lab or go to an assessment center, are actually much lower. And so you can actually quite often rely on the positive as being a true positive. Now, what can sometimes happen, though, is that it could be an indication of a positive for an infection that you had in the past, in the remote past. And so that's not really some people call that a false positive. And so that in that way, sometimes you can pick up older infections.
Okay, so even if it picks up older infections, either you had it or it's still in your system, but it's not a false positive.
The true false positive rate is very low for this test compared to other tests, for example. A lot of it is dependent upon what we call the pre-test probability. Now, that's a very medical term, but what it means is how likely are you when you get this test to really have COVID. And so that's why we test people who have symptoms, who have been in close contact. And because then if you get tested and you're positive, the likelihood of that test being positive and being a true positive is higher as well.
Right. We've spoken about this before as well. There are other factors involved. Of course, the test is your ultimate test, so to speak, but how likely are you to actually have it as well?
Exactly. Yeah.
Okay, and so now we have another question by two people again. Nicole and Jess have similar concerns about masking with children. So I'll read out Nicole's because it's similar. Nicole asks, I have concerns with masking children for such long days for months now in school. She says she's asking for evidence and research supporting that there will be no long-term repercussions socially, mentally, emotionally for children who are wearing these masks for so long. And of course, physically. Please help reassure the people with evidence and proof that masking their children isn't going to cause harm either in the long or the short term.
Okay, well, I can say that masking in schools is one of the public health interventions that has certainly worked and has helped to keep cases down in schools. I mean, this is really one of our good news stories. I can say in the city of Toronto, we have maybe a dozen outbreaks in schools, and that's out of 1,200 schools. So it's very, very low, and that's really good for now. And, you never know what the future holds, but the public health measures like wearing masks are helpful. Now, in a school day, a child is not wearing a mask continuously for the whole school day. Mm-hmm. Mask breaks are built into the school day. And so I think that's really important to know. It's not like when I go to the emergency department and I wear a mask and I wear it for the day. There are breaks built in so that a child can take on and take off the mask. A child is certainly not obliged to wear a mask. If they feel like they need a mask break, there are guidelines as well on how they could do that, including when they go outside for recess and how to do that safely as well. So we can say in the short term, the masks are benefiting because they're preventing the spread of COVID. There's no indication that wearing masks have any long-term effects. I mean, we've seen healthcare workers have to wear masks routinely, daily in places like the OR and have had no long-term effects from that. And so it's certainly not intended that kids are going to have to wear masks forever. I mean, there is hopefully an exit strategy here with COVID and with the pandemic. And so right now, I would say the benefits of wearing a mask certainly outweigh the risks.
Right, absolutely. And like we've spoken about so many times, like you said, masks have been used in medical settings for decades now. And there have been no adverse effects when it comes to immunity or oxygen levels or anything like that. So in terms of even long-term physical effects, for the most part, there's been no evidence of that.
That's right. And I think also in the school setting, it's important for children to wear masks that feel comfortable to them. And I think that that's also part of the learning is for each child to know which one feels comfortable for them, how to wear it properly, because wearing it properly actually helps with the comfort as well.
Yeah, absolutely. Okay, let's go on to some other submitted questions here. Solus Silver on Twitter asks, with the survival rate of coronavirus almost 100% without a vaccine, what will the purpose of the new vaccine be?
Well, we're hoping that the new vaccine will help those who get vaccinated to be protected. Just like vaccines that we have for other diseases, if you're vaccinated against measles, the likelihood of you actually getting measles, even if you're exposed to someone with measles, is actually very low. And so that's what we're hoping with COVID. It will then, the more people that get vaccinated, the less coronavirus will be able to spread. When you reach kind of a critical number, we call that herd immunity, where you have more people that are protected. It acts like a wall to prevent the coronavirus from coming and spreading in a community.
Right. And I mean, I think we speak about this all the time. Just because survival rate is high doesn't mean you want to risk catching it, because we don't know the long-term effects. It affects some people worse than others.
Exactly. And we know that it disproportionately impacts those who are older. They're more likely to get severe illness and die. We also know that people who are lower income, who are racialized, who may live in poverty, like they are have higher rates of COVID as well too. And so we need to protect some of all kinds of different vulnerable segments of our society as well.
Right, right. And then another vaccine-related question, actually, Bill asks, has or will the virus change into something else that the current vaccine will not be effective against?
It's a good question, and we don't quite know the answer to that as well. A lot of, variants on the virus or the bacteria, and whether the vaccine will protect against it, depends on the actual vaccine and how it provides protection. And so, for example, the flu vaccine, the way it's made, if there are variants in the flu, the vaccine doesn't necessarily protect you, though there can be cross protection compared to some other vaccines. So I think we'll have to wait and see on this one, whether if the coronavirus changes, if it mutates, and whether the vaccine will still continue to be effective.
Right. Yeah, because right now we've just heard of a vaccine that's 90% effective, but nothing has been rolled out. It's still under testing. So there's still a lot to come in terms of an actual viable vaccine.
That's right. Yeah. And we're closer today than we were even yesterday.
Yes.
And so, but yeah, we probably won't be able to answer all of those questions right away, but they are certainly ones that we need answers for eventually. Yes.
Absolutely. Okay, let's take some live questions that are coming in right now. Roman asks, how are you actually treating positive cases? Are we using vitamin C in hospital settings?
So in a hospital setting, I mean, there's a number of different ways that you can treat someone who's very sick with COVID. There is an actual drug, a pharmaceutical drug that is available for very severe illnesses. Often you will treat the symptoms. If someone is dehydrated, you'll treat that. And so you'll treat things that way. The use of vitamins like a vitamin C, I don't know of any studies that have shown it to be an effective treatment for COVID-19 just yet, though there may be studies underway.
Okay. And then let's do another live one here. Rebecca asks, why can we be in a restaurant with many people, but we cannot have a spouse with us when we need them at the doctor's office?
So, well, right now in Toronto, indoor dining is closed. So, I think what we're seeing in terms of the visitor policies at healthcare settings is because visitors can come, the more visitors you have in and out of a place, the more you could potentially bring COVID. And I think we've certainly seen that. We've seen that in long-term care homes. We've seen that related to some of the outbreaks that have occurred in hospitals that we actually talked about on one of our sessions here. Why are outbreaks occurring in hospitals? And some of it has to do with the more people come and go. The virus is spread by people. It's not by things or by places, it's by people. And so the more you can limit people coming and going, the more you can limit the spread of the virus. And so that's why some of those visitor policies have been put in place.
Absolutely. Just on a personal note, I had to go get a blood test recently, and I am very needle phobic. And I had to be brave, and I had to leave my boyfriend outside, and had to go and do it myself. And, you just have to be respectful of those policies right now, because even the nurses at all of these centers are so at their wits' end trying to explain to people, why they're not allowed to bring spouses in and things like that. So one just has to sort of, at this point, suck it up, be brave, and go in. And I know that's not the case for everybody. Of course, it's not as simple as a blood test for a lot of people, but at this point in time, just like you said, it's people that are spreading it. So the fewer people that are in there, the better.
Yeah, and I think it's important to know, though, that visitor policies, like in a hospital or whatever, in really critical situations or people who need support, like a child who needs their parent there, I mean, there are allowances that way. I think we have to be creative on how we can get our support, like, to video call in our spouse when we're in with the physician trying to understand things so that they're still included, though they physically might not be right beside you, to reduce those risks.
Right, absolutely. I will take another live one here. Emma asks, how can the vaccine be 90% effective on humans if it wasn't tested on humans?
The vaccine is being tested. So the phase 3 clinical trials are using humans. And so it is being tested in humans right now.
Okay. And then let's see, do we have any more live? Okay, let's go back to the submitted questions that we have over the week. Gavin asks, using the Ontario government's own graphs, is it not true that we are no longer in a pandemic, but COVID-19 is now endemic and the majority of cases are asymptomatic? He says there doesn't seem to be proof of a second wave in those graphs.
If you look at the graphs, you'll see a first peak in what we call the wave 1, and then kind of a low number of cases over the summer, and now the cases are starting to rise again. So that's what we're calling our wave 2, or the second peak. And that's, whether it's, we call it a pandemic because this is a new virus that was introduced, and we're hoping to be able to combat it. Ultimately, though, even pandemic strains become endemic, and so we saw that with H1N1. That was in 2009, and that H1N1 influenza strain continues to circulate in the community every year when the flu comes. So you can expect that the pandemic will likely end up endemic. We will continue to have COVID in our society. It may be difficult to completely eradicate the virus, at least in the short term. But with something like a vaccine, we're hoping that we can we will be able to carry on with more of our lives despite that.
Right. Similar to now, like you said, we have the flu every year. Everybody gets vaccinated, or hopefully everybody gets vaccinated, and then we just carry on with our lives as much as we can, with protections. You still don't sneeze out into other people's faces, right?
That's right. Yeah.
Okay. Let's see. Cindy asks, this is slightly long, but Cindy asks, compared to the first wave, various public health measures have been taken and various changes have been made to our behaviors, same in hospitals as well. In light of this, would it not be considered that 1,000+ case count be less alarming now than it was in the spring? The rate of transmission is technically probably lower compared to the spring, and the healthcare system should be able to handle more positive cases. So is such a high case count still such an emergency?
Actually, you're right, Cindy. Like, that was part of actually the first question. It's not just the number of the case count. It's all of those other things, like what is our healthcare capacity? Who's actually getting sick? Are they getting so sick that they're ending up being hospitalized? Are we ending up with lots of deaths? And so we are seeing a difference in our wave 1 versus our wave 2. And so it's not just the absolute number that we need to look at.
Right. So Ray asked, well, first Ray says, thank you for taking the time to do the AMA. And then he asks, if we should be throwing away takeout food packaging and washing our hands before eating, should we not still be wiping and washing groceries? Because he says, I'm hearing more and more that people don't think COVID is spread on surfaces, but what are people washing their hands for if it's not for getting contaminated from surface contact? And could contaminated surfaces not potentially include those grocery items as much as anything else that our hands are touching?
Okay, so what we know, we're learning a bit more about surfaces, and we know that on things like paper, COVID doesn't really survive very long. A lot of our grocery packaging is that. There's no question that the fresh produce, you need to wash it as you usually would. But if you had, say, like a box of cereal, what's the likelihood that COVID was on there? If it was on there, that by the time you brought it home, it would still, if you touched it, infect you. Well, that's why we wash our hands, because if it was potentially on there and it was potentially still viable, by washing your hands, you're making sure that you don't get it. But we don't actually think that it survives that long on those kinds of surfaces. That's why we don't say when you get packages in the mail that you need to wipe them down. But again, COVID is spread through people. And so when you're going through the line in the grocery, the bags, like certainly those surfaces that you put your bags on before you put them away, it's a good idea to wash those. We don't know definitively, right? But we can certainly say that it's more predominantly spread from that close contact with people and less spread. There's less evidence that it's spread through things like packaging and surfaces. Okay.
Well, that's good to know though, because I don't touch anything when I go outside. My hands are like this all the time. Maybe I can relax just a little bit. Okay. Diane says, kind of related here. She wanted to know, since we're all using hand sanitizer, can this create anti-resistance bacteria and superbugs?
So the hand sanitizer is alcohol-based. There's no antibiotic in it. Usually the superbugs are related to a medication, an antibiotic or an antiviral that then the bug gets accustomed to and can create that superbug, so to speak. But with the alcohol-based hand sanitizer, what you're doing is you're using the alcohol as a cleaner, so to speak, and now, anything is possible, whether you could have a virus or a bacteria that can survive alcohol. That's the real question. But we know right now for COVID that alcohol-based hand sanitizer for COVID, 60 to 90% is effective to get rid of it.
Okay. Let's see. Do we have any lives? Not right now. Okay, we'll continue with our submitted questions. Renu asks, if I'm positive and I've quarantined for the proper amount of days, how long after that should I get tested again?
You shouldn't, Renu, you shouldn't. I mean, unless there's a very specific reason why you need to. If you tested positive, you're otherwise healthy, you weren't hospitalized, you don't have a very weak immune system, 10 days from when your symptoms started, or if you have no symptoms, 10 days from the day that you got tested. After that, you're considered no longer contagious, as long as you don't have a fever anymore. Your symptoms are getting better. Maybe all you have is that little cough. Well, then 10 days is enough and you don't need to get tested again. And the reason when I say that don't get tested again is because you can still get tested and be positive, but it doesn't necessarily mean that you're still contagious.
Right. Yes, we've spoken about that, a fair deal. And like you said, 10 days, maximum 14 days was the recommendation earlier. Thereafter, if your symptoms are done, you're clear.
That's right. Yeah.
Okay, and then more related questions with this kind of thing. Chris asks, if an employee was in contact with a contractor that tested positive, however, that same employee tests negative, can they return to work or should they get a second test before returning to work?
If they were a close contact, they're required to stay home for the full 14 days, whether they get tested or not. Okay. And so you can't, if you're a close contact, you can't say, okay, I got tested, I'm negative, now I can go back to work. No, you got to stay off for those full 14 days.
Okay. Right, so this is the distinction then with the close contact as opposed to just the negative test. Even if you test negative, because we've spoken about this so often, you can test negative on day 1, but you could test positive on day 7. And so you have to wait the whole 14 days.
That's right. That's right.
Okay. Let's see. Fariha asks, if a person had a corona infection in the past, but is not sure whether they had it or not, how long after the infection can you detect those antibodies in the system?
So the antibody test, it's actually not readily available. You can do it. There seems to be some waning of those antibodies when you do the antibody test. And even with the swab in the nose, that's not an antibody test, that's a PCR test. That one you could be positive intermittently for, we're saying now 120 days or so. And with the antibody test after a few months, it could be undetectable. So, but it doesn't necessarily mean that you are not immune. It just means that the antibody response that you're testing is lower, because we know that with this virus, the antibodies test B cells that are in your body, and we know that you tend to get more of a T cell response. And so the antibody test is not testing for that specifically.
Okay. Nick asks, I love going outside with the nice weather. It's good for my mental health. And I train with 2 people and we distance as much as possible. We kick the ball around. We use some drills with some sort of distancing. Are the chances still relatively low that I will catch COVID?
As long as you're not within 6 feet of others. And so I think that that's the real telltale marker here. You know, when you're kicking the ball around, how close are you to each other? Are you making sure that you wash your hands before you go? Making sure that everyone is not sick when they go. There may be some indication that when you're exercising with hard cardio workout, that maybe six feet might not even be long enough, and you may need to actually distance for longer. So instead of 2 meters, try 3 meters. So I think those are the precautions that I would say. If you're concerned, you could wear a mask when you're doing this as well. That would give you added protection as well.
Right. S asks, is it okay to have cleaning ladies come in to clean for 3 or 4 hours when none of us is home? They don't wear masks when cleaning and the windows are usually closed.
So again, the fact that you don't have close contact with them is a good sign. I think it's still important if they come into your home to check and make sure they don't have symptoms when they come. If they can wear a mask, that will be helpful, because then their droplets will not be spreading around the house. I mean, there is obviously that risk of contamination, that their droplets, if they were contagious, could be on surfaces. Again, so what I would say is that you should wash your hands and make sure that your hands are cleaned as well. Right.
And we spoke about vitamin C just now, but Kimmy has another question about vitamin D. She asks, is it recommended to take up to 4,000 IU of vitamin D daily to prevent the severity of COVID symptoms?
So again, I'm not aware of any confirmed guidelines that are recommending doses of vitamins for prevention for COVID. I'm not aware of any studies that have proven that definitively.
Okay. Jason asks, why is bed census summary data not released, analyzed, and reported along with daily infection numbers? Wouldn't this data go a long way to educate the public on why we need to adhere to public health measures?
Yes, good point. So actually, if you go to our website, Toronto Public Health's website, we do have a monitoring dashboard where there is healthcare capacity as an indicator. And so that gives you a sense. Right now, we're in the green for the healthcare capacity. I just was on there this morning, which means that we do have capacity for our beds, for our ICUs in the healthcare system. And so that certainly is a really important metric, and it is available.
Okay. Okay, I think people need to just visit the website more often, because there seems to be a lot of information there. We're only too happy to provide it, of course, but there seems to be a lot of metrics available that are really useful if you're really interested in getting the nitty-gritties of everything.
It's so great to see people so interested in the data, and I'm so proud to say that we actually have a lot of data available. There's also another neat one is the graph, the map of the city, and it shows recent cases. It shows by percent positivity and by cases, and so we're all trying to learn so much and to understand more, and so some of this data is really helping us to do that.
Right, absolutely. Okay, this is a simple one. Emmy asks, what if you have some symptoms, but not all of the symptoms of COVID-19?
You could have no symptoms. You could have just one symptom, and it could still be COVID-19. So if you have even one symptom, you should go and get tested. The symptoms themselves, having 5 of them or none of them, are not necessarily indicative of how severe you'll even get sick or even how contagious you are.
Okay, and we have another live question coming in right now. Mitchell asks, I ride my bike to and from work every day. Is it best practice to wear a mask to protect from airborne cross-contamination?
So you're not likely to get airborne spread of COVID when you're riding your bike outdoors. What we know about airborne spread for COVID is it's really these aerosols. And the aerosols are the very tiny droplets that come when we're speaking or sneezing. And they may be in the air and may last in the air for longer than, say, those larger respiratory droplets. But if you're in an outdoor setting where there's, good air movement, the air is constantly being diluted, so these aerosols are diluted, the likelihood of you catching COVID, especially when you're riding your bike, is low. Now, if you were in an outdoor setting that was very crowded, I would certainly say you should wear your mask for added protection.
Okay, and I hope I'm pronouncing this right. We have another live question coming in from Nigeria today. Odumuyiwa asks, how come we have less than 1,200 death cases here and in the Western world with state-of-the-art facilities, but the cases are higher, but here we're more vulnerable to such a pandemic?
Sometimes the case numbers are very indicative on who is being tested. And we saw that in our first wave of the pandemic, where we knew not everyone who had COVID, who had symptoms, was getting tested. And so I think sometimes you can't always compare between countries, even within a city like ours, even within a province like ours. We can't always compare our numbers in the second wave to the first wave, because the testing criteria makes a big difference on how we can understand what's going on.
Right, absolutely. And let's see what else. Okay, we go back to our submitted questions here. Soma asks, what is the effect of working the midnight shift on your immune system and the ability to prevent getting sick or contracting this virus?
Okay, so I'm not aware of any specific data that shows night shift is more associated with COVID-19. I think what I would say is, if you work the night shift, I know how tough that is because I've done night shifts myself. But it's really the close contact that you might have. And I can say for sure that usually when you're doing night shift, there's less staff that are working. But sometimes when you work the night shift, you tend to buddy up more with your colleagues, and you might actually think that you don't need to wear a mask because it's the night shift, or you can sit close to each other and have your meal together because it's the night shift. And I think that's what the bigger risk is for the night shift right now related to COVID.
Right. Okay. I'll try and we have only 2 minutes, so I'm going to squeeze in a couple here. Shelley asks, when will the rapid testing spit test be available for all regions? Will the identified hotspots be priorities?
So we're still waiting to get further details on that. It was spread out to the provinces. There are certain places in the city that will have it available, but it's not going to be available to anyone who wants it, or even to the public. It will be used in very specific situations. We've talked about before how right now some of the use of these rapid tests will be in places where they don't have access to a lab, like in some of the northern or remote communities, for example. But some of the kits are being used in the city, like in a hospital setting, where it's really important to get that result right away, and where but the tests are still requiring confirmatory testing after. Okay.
So it's just like kind of almost a stopgap, like you immediately get it and then you still need to clarify it later.
That's right. And I think it's important to say that these new tests are new. And so we're going to learn more about them before we actually have them more readily available.
Right. Okay. I'm going to squeeze in one last live question.
Okay.
One last live question. Tatiana asks, do people that get retested get counted in the statistical data of daily numbers?
Anyone who is lab confirmed positive is counted. Now, if you had 5 COVID tests, you would only be counted once. So we don't recount you as 5 times. Now, there are very few people that would be retested and tested positive, but it would only be counted. You would only be counted once.
And that's the same if you get reinfected, because we've seen people getting reinfected as well.
We haven't had any confirmed reinfections, like really confirmed reinfections, where we know that it's a separate virus, genome. And so in that case, you could be counted again because it's a separate infection, but we haven't seen that yet here, as far as I know.
Okay, wonderful. And that brings us to 1 o'clock. I took it right to the minute. Thank you, doctor, for joining us and giving us your time again today. Thank you to everybody that asked your questions live and participated today. We'll see you next week.
Okay, thanks. Bye-bye.
Bye-bye.